Welcome to Webinar 1 of the Adverse Drug Events Opioid Starter Pack. My name is Jeff Berman at the Michigan Health and Hospital Association Keystone Center, and we're bringing this presentation to you on behalf of the Great Lakes Partners for Patients. In the next hour, we will be covering why this work is important, how to establish a team, best practices, understanding the measures, completing a gap analysis, and first steps. Now I'd like to introduce our presenter for the webinar, Dr. Roy Soto. Dr. Soto is an anesthesiologist at Beaumont Hospital in Royal Oak, Michigan. Following his residency at UCLA, he joined the faculty of the University of South Florida in Tampa, and then the State University of New York at Stony Brook. In 2007, he was recruited to Beaumont Hospital to start an anesthesiology training program, and he is currently the residency program director. He serves as a professor of anesthesiology at the hospital's affiliated medical school, is the physician champion for MHA Keystone work around pain management, and his research interests include patient safety, enhanced recovery after surgery, and service excellence and patient satisfaction. Dr. Soto, welcome.
Thank you so much, and thank you everybody for listening in. Today we're going to talk a lot about pain. I'm going to focus a bit of the conversation around perioperative pain. Again, I'm an anesthesiologist, and so pretty much everybody I take care of has had an operation, and that's where a lot of pain starts. And if you look at the statistics, we know that a tremendous number of patients are addicted to pain medications and overuse or abuse pain medications, and a lot of that starts from prescription medications, which of course many of us have heard about in the press. And so talking about the perioperative pain, where patients receive pain medications after an operation or after a dental procedure, I think is an important thing to start with. So why is this important? Again, as I mentioned, the President, the government, the MHA, the Great Lakes Coalition, and many, many others are very interested in the fact that more than 100 people die from drug overdoses every day in the United States, and most of these deaths are not caused by heroin and morphine on the streets like many people think about. They're caused by prescription medication. There certainly is a cost associated with this, and you can see on this slide how many emergency department visits were related to pharmaceutical adverse events. And if you monetize that, that certainly makes a big dent in the healthcare costs in the United States. And then there's obviously also costs to patients, to their families, to the staff members, to the hospitals, to staffing models that really are significant and bear paying attention to. So we're going to talk a little bit about the goal. And the goal of the current HIN project is a 20% reduction of adverse drug events related to opioids in the next 3 years. So basically, in this 3-year period where we're really focusing on this, we're trying to decrease the risk of these adverse events significantly. And the project will assist hospitals with strategies to implement these best practices in ways to reduce opioid-related adverse events, improving appropriate pain management, decreasing the usage of opioids, and enhancing patient expectation management, all of which we're going to talk about today. Also, I think it's very, very important before we fix something, we need to know what our baseline is and to really focus on how we can achieve goals based on what our baseline is and then moving from point A to point B. So before we start, and I think you all are listening to this and you are the choir, you are the people who are very, very interested in this issue, and you have signed on to the Great Lakes Collaborative, but you can't do all this work alone. And so we're going to talk at the very end of this slide deck about building a team, but I think it's really important for everybody to do a gut check. Is your hospital ready for this? Do you really want to make a difference, or is this just kind of a side hobby of somebody who's doing this in addition to the 7,500 other initiatives that they're working on? Is there really an urgency to this? Does your hospital really want to focus on this? I hope they do. Certainly the Joint Commission is interested in this. Certainly statewide and national safety collaboratives are interested in this. But there has to be an urgency. There has to be a willingness to do this job. There has to be leadership support. In many of the hospitals I've spoken with this about this at, there has been great interest by the worker bees, but there's not been a lot of interest by leadership. And then at other hospitals I've worked at, there's been interest from the leadership position, but there's not been a lot of interest from the worker bee point of view. So I think it's very important to make sure that you have your own interest and you have leadership support for this initiative. Who owns the effort? We're going to talk about when we talk about teamwork. We'll talk about resources as we go through this project. I think those will become evident as you move through the gap analysis process, which we'll be talking about. And then, ultimately you're going to have to decide if you're ready or not ready for a full-scale change. I'm not sure that this entirely requires a quote-unquote full-scale change, but it certainly does require a change of educational focus and a change of practice patterns. So what we'll talk about initially is the experience that we've had with the Michigan Hospital Association, both with the Surgical Collaborative and the MHA Pain Initiative. So we're going to talk about pain, we're going to talk about opioids, we're going to be talking about multimodal analgesia, healthcare literacy, value-based care, and expectation management, and the other things that you see on this slide. So let's start back in 1999, 2000, 2001. That's when the Joint Commission decided that pain would be the fifth vital sign, or should be the fifth vital sign. This came from a VA report, which did a very, very good job talking about the dangers of opioids. They did a very good job of talking about risk stratification, multimodal analgesia, and there was this little line in the publication that said pain should be considered to be a fifth vital sign. And unfortunately, that was the only thing that was lifted from that publication. And there was a lot of press about how we really needed to focus on pain management, and nobody understood a patient's pain like the patient. And we know that pain is a big deal. We know that acute pain causes sympathetic activation, which can cause tachycardia and hypertension. And over on the left side of the screen, you can see that increases oxygen consumption, can lead to myocardial ischemia and all these other bad things. We also know that pain causes fear and anxiety and sleeplessness and helplessness, and patients can't participate in their rehabilitation like they should. And certainly if you're having upper abdominal or thoracic pain, you're not going to be able to take nice deep breaths, and so patients splint. They take shallow breaths, they develop atelectasis, and they have an increased incidence of hypoxemic events. So that's all bad. So we know that pain is bad. We know that it hurts. We know that it increases sympathetic activation, and we know that it interferes with recovery. We think we do a great job of pain control. This is a study that was repeated 3 times, and it looked at ambulatory surgery patients, and it asked them during your surgical stay, so during those 2 or 3 hours in the hospital after your operation, what was the most pain you had? And if you kind of add the severe and the extreme numbers together, you get about 30% of people say they had severe or extreme pain during that initial 2 to 3 hours after surgery. Now, I'm an anesthesiologist, and I think that I do a pretty good job of dropping my patients off in the recovery room, and they're unconscious, basically. So I think, hey, they've got no pain, they're doing great. But what happens when I leave is that pain increases very rapidly. Pain increases as patients move. It increases as we get our patients dressed and we make them walk. And so it is not unexpected that patients should have a lot of pain after surgery. And I think there's a lot of room for improvement of how we treat that pain. Again, as an anesthesiologist, I give patients medications in the operating room that wear off in 2-3 hours, and patients stay for longer than that in the hospital. And so I think there's a lot of room for improvement. And I know this is an anesthesiologist-specific talk, but intraoperatively, there are a number of different improvements that we can put into play to try to improve this. We know that there's a federal focus on patient satisfaction, and probably everybody listening in on this knows about HCAHPS scores. There are 7 domains of HCAHPS scores, including communications with doctors, communications with nurses, and so forth. And one of them is satisfaction with pain control. And what this slide, it's not the greatest slide in the world. I take credit for that. I created the slide, but it's not the greatest slide in the world. But what it shows is that the HCAHPS score that is most closely correlated to all the others is pain control. In other words, if a patient is happy with their pain control, they're happy with everything else. If they're unhappy with their pain control, they are unhappy with everything else. And so it's very important that pain control is addressed if you care about patient satisfaction. And a big chunk of that deals with expectation management, which we'll talk about here in the future. Now, I took part in a study. My name is buried there in the middle of this, in Florida. This was published in 2005, but we did the study in 2002, 2003, which was right around the time that pain became the 5th vital sign. And we and others, there are other institutions that have published the exact same finding, found that once we started focusing on pain as the fifth vital sign, we started hurting our patients. I'm going to let that sink in a little bit. Once pain became treated as the fifth vital sign, we started hurting our patients. And the way we did that is that we treated their pain purely based on a numeric score. In Florida, as a matter of fact, the Florida Board of Medicine at the time put forth a ruling that pain needed to be treated as a fifth vital sign, and an algorithm was published in the state that said that if an inpatient had a pain score greater than 7, they had to be treated as a pain emergency, and they had to receive a rapidly acting potent opioid, period, regardless of the patient's respiratory rate, level of consciousness, or comorbidities. And so what we found is that at our institution, this was the Moffitt Cancer Center at the time, that the number of Narcan rescues and the number of reported opioid overdoses greatly increased once pain became the fifth vital sign. And when we pulled out the specific patients that were harmed by opioids and you looked at their respiratory rate and their level of consciousness immediately prior to the patient receiving an opioid, every single time the patient was sedated and not breathing more rapidly than, say, 10, 12 times a minute. And so it was an inappropriate way of treating pain based purely on a subjective numeric pain scale. And so as a result of this, and other studies that found the same thing, the Joint Commission kind of changed their tune. And in 2012, the only sentinel event alert that the Joint Commission published was this one, which was safe use of opioids in hospitals. And again, they did a very, very good job of talking about patient risk factors, talking about multimodal analgesia, and talking about the potential dangers of treating patients based purely on a number. And so for the next few slides, we're going to talk about some of the things that came from this report and some of the recommendations and how we can improve pain care in the United States. So first off, let's talk about opioid monotherapy. Premier is a group purchasing organization that keeps vast amounts of information about hospital prescribing patterns. And this was an analysis that I published as an abstract at the Postgraduate Assembly of Anesthesia last year in New York, which looked at 8 million patients in 2012 in all of the Premier hospitals that received opioids for pain. And if you looked at the patients who received IV opioids, just over half of them, 51%, received opioids and nothing else. In other words, they did not get Tylenol, they did not get nonsteroidal, they did not get anything other than opioids. And that sounds surprising, but that's pretty common, right? We have a patient who has pain, we put them on a dilaudid PCA, or we give them oxycodone, or we give them something else to the exclusion of all other medications. And we know that that's not the right way to practice. We know that we should use different medications. This is the World Health Organization's analgesic pain ladder, or pain pyramid, if you will. And this is not an MHA publication or picture, but this is, again, an internationally accepted way of treating pain, that if a patient has mild pain down there on step 1, you use a non-opioid. If they have mild to moderate pain, step 2, you continue to use the non-opioid, and then you add an opioid for mild to moderate pain. And if they have moderate to severe pain, step 3, you do what's in step 1, you add what's in step 2, and then you also add what's in step 3. And so you are stacking your medications one on top of the other. What we frequently do is we see somebody who has a little bit of pain and we give them Motrin. And then we have somebody who has severe pain and we skip Motrin and we go right to the opioid, when in reality we should be giving that patient with severe pain the same medicines that we would give somebody who has mild or moderate pain, and then, again, stack medicines on top of each other, with the goal being that you're using safer medications as the foundation for pain control, and then you're adding the less safe medications at the later points in care. We know that multimodal analgesia means using different medications that have different sites of action and different mechanisms of action. So, for instance, local anesthetics work wherever you stick them. Anti-inflammatory drugs like Motrin, which is ibuprofen, work in the periphery. We know that medications like alpha-2 agonists, which is drugs like clonidine and dexmedetomidine, which we typically use in the perioperative period, work in the central nervous system. And we know that opioids work in the central nervous system, meaning the brain and the spinal cord, and then acetaminophen works up in the brain. And so there's different medications that work in different ways, and we should be using these all together, or many of these together. And there are more medicines than these available, which we'll talk about. So I'm an anesthesiologist. I like giving medicines. I like sticking needles in people. So I'm going to get out of my anesthesia box and talk just briefly about the top part of this slide. Certainly, using non-pharmacologic techniques for pain management works. You can use ice, physical therapy, massage, stretching, acupuncture, counseling, which we'll talk a lot about here in a little bit. And so you don't have to use pain medications. And certainly, if you are using pain medications, you can offer patients some of these other approaches. I trained, for instance, at UCLA in Los Angeles, and many of our patients, or many of our chronic pain patients, were using acupuncture as part of their routine therapy, and the National Institutes of Health published specifically what acupuncture works for. There's great evidence-based medicine for acupuncture if you're interested in reading about that. In addition to these above, we have the medications like we've talked about. So acetaminophen is available orally, rectally, and IV. All three formulations work very, very well. The IV formulation works more quickly and certainly works very, very well for patients who are NPO. Alpha-2 agonists, like we talked about, are primarily used in the perioperative period or the ICU. Gabapentinoids are medications that were originally used for seizure treatment, but we found 20, 30 years ago that these medications work for lancinating types of chronic pain, people who have shooting electric shock-like types of chronic pain. And then more recently, we've learned that if you give patients who are having surgery gabapentinoids around the time of surgery, you use less pain medications, and the patients are more satisfied with their pain scores. They have lower pain scores, I should say. So as a matter of routine, we are now using gabapentinoids for our patients who are having major abdominal operations or cancer operations. For instance, we give them a dose preoperatively, and then we continue it three times a day for 3 days postoperatively. Local anesthetics, we all know that if you numb something up, it hurts less, but we also can give local anesthetics IV, both in the operating room and afterwards on the floor. That works fine. There's good publications that show this. And there are newer formulations of local anesthetics like liposomal bupivacaine, which are long-acting medicines that work up to 72 hours that can certainly improve pain care. NMDA receptor antagonists like ketamine work very, very well also to control pain. There has been a hesitancy to use medicines like ketamine for a while because it kind of freaks patients out. They can have dissociative sorts of symptoms that are very unpleasant. But we have learned that if you keep the dose down to, say, 0.5 milligrams per kilogram, you can decrease postoperative pain scores and decrease opioid use also, and not just for surgical pain. It's also been shown in patients who have chronic pain that NMDA receptor antagonists work very, very well for pain control with much less side effects than opioids do. And then finally, non-steroidal anti-inflammatory drugs. There's a whole bunch of those available now, both orally and IV, and they all work very, very well. Some of them have different side effect profiles if given chronically, but in general, they all have the same efficacy for pain control. So whenever I ask somebody, hey, what should we use for this patient for pain, they immediately say, oh, we should give them narcotics. And I say, well, is there anything else we can give? And they say, well, we can give them Tylenol. Well, there's a whole lot of other medications that we can use instead of opioids, allowing us to save the opioids for our last step. And I certainly think that opioids have a very good role in pain control. I just think they're overused, and they should not be used as early as they're being used. Now, I touched on counseling once, and this slide really talks about that a little bit. It's a little bit of a difficult slide to go through, but this was a study by Jeff Applebaum, who's an anesthesiologist in Chicago right now. And he asked surgical patients, hey, did anybody talk to you about pain around the time of your surgery? And the take-home message is that top left-hand number of 63%. So 63% of patients had somebody tell them before surgery that they were going to have pain. Now, 63% seems like a reasonable number, but what that means is that 37%, more than a third of patients, nobody talked to them about pain before their operation. To me, that's lunacy. The number one concern that patients have around the time of their surgery is pain. The one guaranteed outcome of every surgical operation is pain, and yet only 2/3 of the time do we talk to patients about pain. That makes absolutely no sense whatsoever. And then we find it surprising that patients expect to have zero pain after surgery. I think that's an expectation in the United States. And then we find it surprising that people expect to get morphine, and more morphine after surgery, because that's what their aunt and their cousin or their friend or the TV told them they were going to have or expect. Whereas in reality, we should be telling patients, hey, you're going to have pain after your operation. That is normal. I'll be able to get it down to a pain score of about 4 out of 10. We'll keep it down to a dull roar. But, getting it down to lower than that is going to give you so many side effects from the pain medicines that you're not going to be able to leave the hospital. Also, if I give you too many opioids or narcotics, your guts aren't going to work. You're going to be constipated. You're going to be itchy. You're going to be sleepy. You're probably not going to be breathing really well. So we need to be careful about giving you opioids. Yeah, we're going to use them for you for surgery, but we've got a whole bunch of other medicines that work really, really well, and so forth and so on. So I think it's important to have these discussions preoperatively so that patients' expectations are managed so that postoperatively they don't complain when they don't have 0 out of 10 pain. That'll affect your pain scores, right? And that they understand that opioids are not necessarily the panacea that they think they are. So as a result of all of what we just talked about, the Michigan Hospital Association launched a number of initiatives, including the MHA Pain Initiative. And we're going to go through a few parts of this that I think are pertinent to the current Great Lakes Partners initiative. We're going to first talk about a gap analysis tool. Then we'll talk about something called the MOS tool, which is the Michigan Opioid Safety Score. And then some of the process and outcomes measures that we measured in the MHA and what we will be measuring with this new Great Lakes Coalition. And then some of the other of the initiatives, the drug disposal tool, and some of the education initiatives that we worked out here with the MHA. So a little bit out of order, but we're going to talk here first briefly about the Michigan Opioid Safety Score. Again, if you treat pain just based on a number, you're going to find that you're going to potentially harm patients and treat pain inappropriately, as we've already discussed. And so what we in the MHA decided to do was try to come up with a new pain score that a nurse could use at the bedside when the patient said, ouch, I want more pain medicine. And the nurse could decide, should I or should I not give this patient more pain medications? And so using the Joint Commission Sentinel Event report as a guideline, we developed a tool that first looked at patient risk. So you can see up there in Group A, you looked at whether the patient had, if they were obese, if they had abdominal or thoracic surgery or a long anesthetic, if they were receiving any other sedatives, or if they were old, if they were a smoker, and they got points for that, up to a maximum of 2 points. Then we looked at the respiratory rate. Was the patient basically breathing fast or slow? And they got points based on that. And so if they had points 0, 1, 2, 3, or 4, you could see down there in the green and the yellow area, that's what the nurse should do. If they were in the safe zone, in the green zone, in other words, we wanted to make sure that we say the patient is safe to proceed with further opioid dosing. And make sure that the patient is getting multimodal analgesia, and you can see that everywhere, that multimodal analgesia is stressed. And as the patient's score goes up, we be very careful with the amount of opioids the patient is getting, or we decrease the opioid dose rather than increasing the opioid dose, which is what we would have done in the past. And then finally, you can see there in area C in the middle of the slide, there is a stop modifier. If you're talking to a patient and they start drifting off to sleep while they're telling you about how terrible their pain is, you need to stop giving them pain medication. You need to stop opioids. You need to notify a primary physician. You need to consider increasing the level of monitoring that patient is receiving, maybe put him in an ICU or a step-down unit, or put a pulse oximeter on him, or capnography, and then consider an anesthesia or a pain consultation. In other words, it's a bedside nurse empowerment tool to let that nurse say, wow, this patient should not be getting more opioids, even though that's what the patient wants. I need to get help. I'm not going to be bullied by the patient, by the family member, by the intern who's saying, yeah, go ahead, give him more narcotics over the phone. So that's how it has been used. It's been used as a bedside tool, and many hospitals in the state and the region are starting to incorporate this into routine care and working it into their electronic medical record. Again, as an attempt, as a means of improving opioid-related patient safety. So the measures that we are going to be using for the Great Lakes Partners for Patients program is going to be the Narcan one. We're going to be looking at the numerator being the number of patients treated with any opioid who receives a reversal agent, and the denominator is the number of patients who receive an opioid. And there are some areas of the hospital where Narcan is given routinely, and that could be in OB after C-sections for patients who are itching. But that should be filtered out if everybody reports it the same way. And so we're looking at Narcan use, divided by the number of patients receiving opioids. So that's going to be requested of hospitals who are participating in this initiative, and we'll talk later on about how to submit that through the Keystone data system. And the reports are going to be available to all hospitals who are participating in this. I think that's important so that you can compare yourselves to other hospitals, because if your number is 84% and everybody else's is 1%, you know you're not doing really well. Drug disposal tool. I think it's interesting that if you are prescribed an antibiotic or a rash cream and your infection goes away or your rash goes away, we throw our medicines away. If you're given 30 Percocet pills because you've had an operation, you only take one because your pain goes away, people will save their Percocet. They put it on the top shelf and they wait for their chainsaw accident when they're going to need it. And that's wrong. So patients need to understand that keeping narcotics around is dangerous. Using medicines for what they're not prescribed for is dangerous. And they need to understand the public health implications, right? If their kids get to the medicines, if somebody else in the family finds them and sells them, that's going to be a problem. And so how can we properly dispose of medicines? Well, what we learned in Michigan was that there was no one way of disposing of opioids. So with the help of the Michigan Pharmacists Association, we came up with a very good drug disposal tool, which has standardized how patients can be educated about this and how patients can dispose of medications. And we can talk about this more in the future, but this information is available on the website. But I think it's also a very nice initiative that other states and other groups interested in this can really focus on. Again, getting rid of those excess medications that are laying around. Now, certainly part of the focus should be on surgeons prescribing fewer medicines. We have a surgeon, for instance, who gives a huge number of narcotics, and he does it because he doesn't want to get the phone call when they run out. And clearly that is convenient for him, but it potentially sets up a situation where a lot of his patients are getting way too many medications. And what we would request of a surgeon like him is that he does a very vigorous education campaign with his patients to let them know that you really need to get rid of those extra medications that you don't use because they're dangerous. And this is just another example of a patient print product that the MHA Keystone Center published, which has now been sent out tens of thousands of times. I think it's an excellent product. It talks about all the things that we've already discussed. Patients should be asking their surgeons, how much pain am I going to have? When will it be at its worst? What type of pain am I going to have? It talks about the dangers of opioids and how they can increase the risk of complications and so forth. It talks about multimodal analgesia, and it explains when a patient should be calling their doc about pain. In other words, when it's abnormal pain and they should seek consultation. As we know, however, education, even though it's attractive and easy and you and your hospital will find people who are really gung-ho about educating folks, education is not the best way of improving patient safety. Anybody who takes part in quality and safety initiatives has probably seen this type of a slide, which talks about the rank order of error reduction strategies. And if you look way down here on the bottom, number 2, education has a low power of improving safety. So in other words, if you have a lecture in your cafeteria tomorrow about opioid-related patient safety, that's going to have a very small impact on improvements in safety. And so the right way to improve safety is fail-safes, constraints, barcoding your medications, locking medications in pyxuses, forcing functions, automation, computerization, that sort of stuff. So even though we're giving a lot we're talking a lot about education, we really need to keep in mind that education is not the be-all and end-all of opioid-related safety. So if we can come up with ways of restricting how many opioids are prescribed, restricting who is prescribing what, I think that's going to be very, very important. Now, finally, we're going to talk about the gap analysis tool. And so a gap analysis tool is a way of figuring out where you are right now. And so when we created our gap analysis tool with the Michigan Hospital Association, we first of all, I should give props to the Minnesota Hospital Association that we modeled ours on. But we came up with what we consider to be best practices. So this, we agree, is a best practice in pain management. And then we designed questions based on that best practice so that a hospital system could look at that and do a gut check and report whether they did or did not do a certain thing and then a report card could be generated saying, hey, this is your gap analysis tool. Compared to the rest of the state, this is where you are. You're kind of behind the times as far as statewide safety goes, and maybe you should improve that. And then we can follow gap analysis data over time to see if hospital systems improve compliance with best practices based on education and the other tools that we've generated. So I'm going to go through some of the findings that we had in our analysis, just by way of example of what can be generated by doing this. And you will be asked to participate in gap analysis. So a gap analysis tool is not a must-do list. You don't have to do everything that's on the gap analysis tool, but it is a list of best practices that if you're not doing it, you may want to scratch your head or do a gut check and say, hey, maybe we should be doing this. And again, this is located on the MHA community site, and we'll talk more about that here in a bit. So we're going to talk just about 5 areas that we found some very interesting things in Michigan. Number 1, whether pharmacy or pain supervises prescriptions, range orders, sleep apnea identification, reversal protocols, and then opioid tolerance. So for each of these, I'm going to show you our findings first, and then we're going to talk about what I think are best practices. So first question. A pharmacist or pain provider provides oversight for all dosing of methadone or fentanyl patches. You can see in our analysis, we had 69% of hospitals said yes, a pharmacist or pain provider is involved in methadone dosing, but 31% they were not. Similarly, for fentanyl patches, a pharmacist or pain provider was involved in 3/4, but not in 1/4 of the prescribing. So we, the MHA, felt that a best practice was that an institution requires a pharmacist or a pain physician to oversee the use of methadone for post-surgical inpatients, and the same for transcutaneous fentanyl for post-surgical inpatients. It just makes sense. These are medicines that your typical family practitioner, internist, or surgeon is not familiar with on a day-to-day basis. They carry certainly an increased level of risk compared to the other medicines that we typically use, and there should be a standardized process. Again, remember about processes to improve safety to ensure that these medications are used safely. And again, we found in our state that 1/3 to a 1/4 of the time that was not happening. So that was certainly an area of an improvement within our state, and certainly areas of improvement within those individual hospitals that were not doing that. Next one, the facility's opioid practices clearly specify that range orders should not be used for opioids. Now, we know that a lot of national organizations have requested that range orders not be used. And what a range order is would be 1 to 2 Percocet, PRN, Q3 to 4 hours for pain. So that's a range order where the nurse can decide, well, do I want 1? Do I want 2? Do I want it every 3 hours? Do I want it every 4 hours? That's a very broad range based on subjective findings. And what should be done, which we'll talk about in the next slide, is you should specify for each particular condition what the patient receives. And so what we found in our state is that a little more than half the time that was not the case. And so, again, lots of room for improvement in the state of Michigan. And I suspect in your hospitals as well with regards to range order dosing. And we have improved that now in Michigan. So, again, range orders should not be used. And for mild pain, there should be specifics. 1 Percocet Q4 hours for mild pain, 2 Percocet Q3 hours for moderate pain, et cetera, et cetera. So there should be very specific orders written for specific conditions. So, again, it removes variability in how somebody treats a patient's pain. Sleep apnea identification. Well, it seems obvious that we should assess patients for a history of sleep apnea. So that left one says the facility has standard policies and practices in place for managing the initiation or maintenance of opioids for patients who have sleep apnea. Well, good job for 3/4 of the hospital that did that, but 1/4 of the hospitals in the state did not do that. They did not check to see if a patient had a history of sleep apnea, which clearly is important when dealing with pain and prescribing opioids. Also, I suspect everybody listening has been initiated into the world of handoffs, and we know that transitions of care are very, very important, and those are areas or times in which patient error or patient harm can occur. So we asked, during your standard handoff or transition for patients who are receiving opioids, do you include discussion of a history of sleep apnea? Half the time, yes. Half the time, no. Seems like that would be a pretty simple way of improving safety if during the handoff you can say, hey, by the way, this patient has sleep apnea, so you need to be careful. And so, again, a significant room for improvement in our state and certainly for the individual hospitals that are over on the right-hand side of that slide. And we just talked through all of those best practices. Next one, a protocol is followed which guides the reversal of opioids and includes the following. On the left, that a reversal protocol is active in all patient MARs, and on the right, that nurses are allowed to administer that reversal without needing to have a physician order it right then and there. So in other words, if a patient is receiving an opioid or a benzodiazepine, is there an active order for Narcan or for flumazenil that a nurse can administer based on that standing order? And you can see there's a lot of room for improvement for both of those in the state. It would certainly decrease delays in care if that were active. So we recommend that MAR reversal protocols be active for all patients receiving opioids and benzos, and that, again, nurses be allowed to administer those agents per these protocols. So there's not an extra artificial step in place that requires a delay in care for these emergency or urgent situations. And then finally, we're going to talk about the issue of opioid tolerance or naivete. So you can see the facility has standard policies and practices in place for managing the initiation of maintenance of opioid therapy, which include on the left side, defining and identifying if a patient is opioid tolerant or naive. And on the right-hand side, you can see that they've PCA and PCEA, which is epidural, the E is epidural, orders prohibiting the routine use of basal dosing in the opioid naive patient. And you can see again, 3/4 of patients on both graphs, of institutions on both graphs, had room for improvement. And we know that patients should be identified as being either opioid naive or tolerant on the MAR and during handoffs. Again, handoffs are very, very important. And patients who are opioid naive should absolutely not be receiving basal rates of opioids. That should not happen in 2016. And so something that is relatively simple to find out in your hospital and hopefully relatively simple to change policy-wise, but probably harder to implement if you're at a hospital like mine where we have umpteen different private and employed groups of physicians that practice in many, many different ways. So given that, I think we need to figure out where your hospital is right now. Many of you listening to this may be doing most of these or all of these and may feel that you are in a pretty good shape. Many of you may feel, hey, wait a second, we haven't looked at this and I have absolutely no clue that pharmacists are involved in methadone prescribing policies at our hospital. So a good way to figure that out is to do this gap analysis. Again, comparing your current practice with a list of best practices, and there are many more than the 5 that I just showed. Those are just examples of why I think it's important and what we found in Michigan. And, you know, this is not a judgmental sort of thing. You really want to understand what your variability is at your institution and how you compare to others in the coalition. And then by doing so, you'll create a list of gaps. And if you're an optimist like me, you consider that a list of opportunities for improvement. So my last slide is this one, which is really talking about establishing a team. You don't know what you don't know, and I certainly didn't when I first got involved in this. As an anesthesiologist, I was a little bit of the odd man out in our hospital system because we had lots of quality nurses that were interested in this and a surgeon or two who kind of dabbled in this, but nobody else really was interested in this. And when we really launched into pain safety at my hospital, we really had to get a lot of folks involved that we really didn't work with a lot. So for instance, the physical therapists. We really didn't work with a physical therapist ever in anesthesia, and the surgeons and the nurses, I mean, they certainly see the physical therapists, but they don't know what they do or why they do it. But the physical therapists are key members of the pain control team. And so creating a team that includes a project champion, who hopefully is a senior leader who's going to provide support and from administration is very important. Having somebody who knows how to identify physician, pharmacy, data, safety, quality, emergency medicine, surgical services, all these folks, and bring them together is important. So if you have the resources to hire or identify a project manager who can do this, if not full-time, at least part-time. That's very, very important. Somebody who could shepherd the process and, again, identify folks, get them into a room together. And then, again, talking through all the things that we've mentioned today, going through the gap analysis tool, farming out different questions to different people on that team is very important. So this is work. So this is not as simple as you may think it is initially. It's going to require some manpower and identification of key shareholders in this issue. And so I would like to encourage you to first start with an administrative champion. Find somebody in your administrative staff who's willing to commit time and resources and office and, meeting rooms for this sort of a thing, and a secretary to start calling people to get them to come to meetings. And then again, identifying a team leader who can really identify different champions in the different hospital areas that are affected by this. And so with that, I will stop and I will turn it back over to the MHA team or to the Great Lakes Partners team, and they will talk more about where to find some of the resources that we've discussed.
Thank you, Dr. Soto, for your presentation. Resources for the ADE for opioids are available on the community site, as shown here on your screen. Down on the left-hand side, you'll see the harm areas. In each area of harm, there will be a starter pack folder and a resources folder. If you look in the starter pack folders in each area of harm, you'll see a link to the gap analysis. You'll see Webinar 1 and Webinar 2. And additional resources for each topic will be available in the resources folder. Here are some of the resources you'll find on the community site. For example, the MOS tool that Roy discussed is available there. Now that you've viewed Webinar 1 for the starter pack, you can work through your gap analysis. Gaps for each area of harm are available on the community site in the starter pack folders. Next, you'll want to view Webinar 2, also in the starter pack folder on the community site. The second webinar will focus on the how of the improvement work. You'll also find the Keystone calendar of educational events on the community site. We have our Quest trainings posted there. Quality Essential Skills trainings, or Quest, is another opportunity to engage in quality improvement efforts. Quest is a 2-day training intended for staff that need a retread on basic quality concepts like PDSA and data. Think of Quest as a Quality Improvement 101 with the goal of arming individuals at the hospital level with the QI and data skills needed to improve. Trainings will be held in all 3 states, and again, dates and locations can be found on the community site. On behalf of everyone at the Great Lakes Partners for Patients, thank you for watching.